Good evening, everyone, and welcome to tonight's special webinar event, Screening Lung Cancer Guidelines and Gaps. Tonight we have SAB faculty members as our presenters. We have Dr. Vritti Gupta. She sits on the Education and Program Committee, and we have Dr. Bradley Icard, who sits on the Advocacy Committee here at the SAB. Before I hand it over to Dr. Gupta to begin the presentation, there are a few reminders. We do encourage you all to ask your questions. You can submit them through the chat feature or the question feature. It's located on your control panel. You also may raise your hand. It's also on the control panel. This will allow us to grant you microphone access and permission if you wish to ask a question. And at this time, I will hand it over to Dr. Gupta to get us started, and we appreciate you joining tonight's webinar.
Are you guys able to see my slides?
Yes, we are.
Perfect, awesome. Well, thank you, Emily, for that introduction. As Emily said, my name is Vritti Gupta. I am an advanced bronchoscopist at Wellstar Health System in Atlanta, Georgia. And I am very passionate about lung cancer screening, and I'm excited to talk to you all about this very important topic on lung cancer screening guidelines and gaps. The way that Dr. Icard and I have structured this talk is the first 20-30 minutes of this will be more a didactic session, and then really the later half of the talk we want it to be more interactive. We want to share things that we have done in our lung cancer screening programs, and then we want to hear from you as the audience about things, challenges that you have faced, or how you've navigated some things that maybe we have faced in our program. So really at any point, like Emily said, if you have questions, if you have comments, please type them into the chat box. And I can see the chat box quite well while I'm presenting, so Dr. Icard will kind of help moderate with any comments that you have while we're going through these slides. Let's get into this. Okay, like I said, very aptly timed talk for this. November is National Lung Cancer Awareness Month. It was also the Lung Cancer Screening Day, November 9th. So it kind of falls right on line with this talk today. Our objectives for today, we want to understand kind of the epidemiology of lung cancer. Why is it that we harp on this? Why is it important for us to look out for this? We'll look at current guidelines for lung cancer screening and how we got to them, understand some challenges that exist in lung cancer screening, and then maybe talk a little bit about what the future of lung cancer screening may entail. So why is it that we talk about lung cancer so much? These numbers here on the right are from 2024 projected estimate of new cases of lung cancer and the number of deaths. And as you can see, about 225,000 new cases of lung cancers to be diagnosed this year alone. And as you can see, #1 cause of cancer-related deaths in both male and female. More than 350 people die each day from lung cancer. And like I said, it's the leading cause of cancer-related death in this country and worldwide. Another way to kind of look at the different cancer incidences over time. So as can be expected, prostate and breast are 1 for male and females respectively. And then lung cancer is #2 for both males and females. As you can see, the trend of this graph, a little bit of a steeper decline for the male population as compared to the female population, which is now just slowly starting to come down. And a lot of that has to do with how tobacco products have been marketed over the last, few years. These are some advertisements that I could find from the last, 100 years or so. And you can see as earlier, as most recent as 1990s, women were still being targeted for smoking. This is from the cover of Cigar Aficionado magazine. So you can say that females were still being targeted for cigarettes and smoking up to quite recently. The overall trends for cigarettes for the last 20 years, as you can see, slowly starting to decline now, but still about 25,000 or 25 billion cigarette packs were sold in the last year alone, and that's still quite significant as far as trends of the cigarettes go. How does the consumption of cigarettes relate to lung cancer related death? So the black line in this graph here kind of follows the trend of cigarette consumption. The gray line here is male lung cancer death rate, and the blue line here is the female lung cancer death rate. So as you can see, the cigarette consumption probably started to decline somewhere here in the 1960s, 1970s, and really the cancer death rate stats lag behind by about 20 years. So you can see that the male lung cancer death rate started to come down in the 1990s. And again, like I said, the female population was still being targeted up until as recently as 1990. So this lung cancer death rate is just now starting to stabilize and presumably has started to decline over the last couple of years. So all of this being said, lung cancer is definitely something that we should be concerned about. And we'll next look into guidelines for lung cancer screening and how we got to that. So these are the most recent lung cancer screening guidelines that were published in 2021 by the USPSTF. And the patient population that they recommend for lung cancer screening is anyone between the ages of 50 to 80 years of age who have that 20-pack-year smoking history and currently smoke, or those that have quit in the last 15 years. And pack years, for those who may not be familiar, is defined as 1 pack per day for a year. And so this is where our current guidelines stand. And as we look through the next few slides, we'll kind of walk through how we came to these current guidelines that exist today. In the last 20 years or so, a lot of different studies have looked at different aspects of lung cancer screening. The two studies that we often talk about the most when it comes to lung cancer screening is the NLST trial and the Nelson trial. Both of these studies were powered to assess lung cancer-related mortality. There's some other studies here on the bottom of this graph which look at unpowered studies, and even though these studies were not powered for things that they were testing for, we still learned a lot of useful information from them. So let's talk about the NLST trial. So this was the first randomized controlled trial that was published when it came to lung cancer screening. It was one of the largest studies that we have to date. And in this study, there were 53,000 patients that were enrolled between the ages of 55 and 74 years of age who had 30-pack-year smoking history, were either current smokers or had quit in the last 15 years. And these patients were enrolled in either a chest x-ray or a low-dose CT arm. And the results that we found in the study that were significant was a lung cancer-related mortality reduction. So about 20% mortality reduction when it came to lung cancer as a result of this study. The study also talked about cancer staging and stage shift, and those are two concepts that we'll talk about in a little bit. So again, to kind of reiterate the main points of the study, if we look at this graph, the red line is patients that were enrolled in the chest x-ray arm. The black line here is patients that were enrolled in the low-dose CT arm. And as you can see, the low-dose CT arm, more lung cancers were found in patients that were screened with a CT exam versus a chest x-ray. And then similarly, if you notice, you have the chest x-ray arm here in red and the low-dose CT arm here in black. 20% fewer deaths from lung cancer when it came to the low-dose CT arm. Now, once this study was published in 2011, we had the first iteration of the USPSTF guidelines that were published in 2014. And in those guidelines, patients were recommended to have an annual low-dose CT, and the age range was 55 to 80 years. And they kept the same 30-pack-year smoking, either current smokers or quit in the last 15 years, and patients that were asymptomatic. Now, one thing interestingly that the USPSTF mentioned in these guidelines were that patients, if they had a health problem that limited their life expectancy sooner than the diagnosis of lung cancer, then those patients didn't necessarily need to be enrolled in the lung cancer screening program. Or patients that had quit smoking after 15 years, after their 15 years, did not necessarily need to be enrolled in their lung cancer screening trials. So this was the first iteration of the guidelines that came out of the NLSD trial. Now, once these guidelines were published in 2014, there was, of course, some criticism that came from the screening guidelines. One of those criticisms being that, yes, we're screening all of these patients, but are we finding early stage cancers that may not have changed mortality? Are we just screening these patients just because we have these guidelines in place? And so interestingly, in this study, you can notice prior to the USPSTF guidelines coming out, in 2004, there was about 17%, early stage cancers that were being identified. Once the guidelines came out in 2013, that number went up to 20%, and 2018 went up to 28%. And as a result of these more percentage of early lung cancers being diagnosed, we also found that there was a 3-year survival benefit as well. So 21% when prior to the guidelines, and then 31% once the guidelines were implemented. And so really this proves that, yes, although we're scanning these patients, we're also having an effect on mortality. And that's where, screening exams play an important role, as we want to capture these cancers early on and impact survivability when it comes to these things. Now, the other thing that is also often pointed is, are we having to screen too many patients before preventing one death? And so if we look at this number, there's about 320 patients that need to be screened for us to prevent one lung cancer related death. And when we compare that number to breast and colon cancer, that number for breast is about 1,900, and for colon cancer about 1,200. So as you can see, the number is far less for lung cancer as it is for other cancers. Not to say that the other cancer screenings are not important, but we are not putting patients putting them through more screening exams for that lung cancer. And so, again, coming back to these 2013, 2014 guidelines, when they were published, another criticism was, did we truly capture patients that, or did we capture all of the patients that could have been captured with these guidelines? Or were there other patients that we should have looked at or could have looked at that would benefit from a change in these guidelines? And so this trial was published back in 2019, and it really evaluated the USPSTF criteria when it came to an African American population. So in this study, they looked at about 48,000 smokers, 67% of whom were African American, and they observed them for about 12 years. And what were the notable findings? In this graph here, you can see that when they compared African American smokers to white smokers, the average pack years for African Americans was 25.8 versus their white smoker counterparts, which were 48 pack years. And these were for patients that were diagnosed with lung cancer. So what does the study kind of tell us? When we look at the median pack years for the white population around 32 versus African American population at 17.5. We also looked at, or the study looked at the USPSTF eligible patients. And so with the guidelines where they stood, there were about 31% white patients that could be enrolled versus only 17 in the African American counterparts. Now, if they expanded the eligibility criteria to reduce the smoking history to 20 pack years, they noticed that there was a significant increase in the number of patients, African American patients specifically, that could be enrolled in lung cancer screening programs. So what does that mean for us? It meant that the guidelines that were in place back in 2014, they were probably too conservative for the African American population, and there probably needed to be an adjustment of pack years that would make the screening program more equitable for the African American patients. After this came the Nelson trial. This is the second kind of largest randomized trial that we have to date, looking at lung cancer screening programs. In this study, there were about 16,000 patients that were enrolled with their age range of 50 to 74 years, so more than the NLST trial. They also reduced that smoking history for the patients, so more than 15 cigarettes a day over 25 years, or 10 cigarettes a day for more than 30 years. They reduced that quit year to less than 10, and similar to the NLST trial, they noticed that there was lung cancer mortality reduction, and there was also that stage shift of capturing the early stage 1 patients. And as you can see there, the study predominantly had male population, 84% male. And when they mapped this out in a subgroup analysis later to see if there was a difference in mortality reduction between male and female, you can see that at year 8, year 9, and even up to year 10, there was more of a mortality reduction in our female patients than their male counterparts when it came to lung cancer screening. So based on that study, we now, like I said, have the current 2021 criteria. Again, to reiterate that, it's for patients 50 to 80 years of age who have a 20-pack year smoking history and currently smoke, or those that have quit in the last 15 years. With this new change in the criteria, as you can imagine, a lot more patients are now eligible for lung cancer screening, as much as 87% increase in the number of patients that are eligible. And that increase in eligibility has included not only female patients, but also had an impact on different racial groups that are more likely to now be enrolled in lung cancer screening programs than before. So you can see the non-Hispanic Black population, the Hispanic, even the Asian population has had an increase in their eligibility than before. And really, what does that ultimately lead to? It ultimately leads to greater gain in lung cancer deaths prevented, and definitely life years gained, as you can see, specifically in women compared to men across all of these races. Despite these change in guidelines or changes in criteria for the guidelines, there are still some challenges that we face when it comes to lung cancer screening. Those challenges still exist as far as disparities in eligibility. We're still facing low rates of uptake. And then, lung cancer screening is not a one and done type of thing. It's something that patients have to come back for year after year. And there's still lack of adherence to follow-up scans that patients are not following through on. So let's first look at the racial disparities. As you saw, between the 2013 USPSTF criteria to now, there was clearly that concern of the African American population. But even now, with this expanded kind of smoking history and reduced age range, have we eliminated all of those racial disparities? And so this study was published in 2015, even prior this was published in 2021, but prior to the 2021 criteria being out. And the study looked at the eligibility of lung cancer incidence to the ratio of lung cancers that were being discovered. And so in this study, on the left, you have the graph for the male population. On the right, you have the female population. And the criteria that I want us to focus on is, they evaluated the 2013 USPSTF criteria. They evaluated an expanded criteria, which is actually the 2021 criteria that exists currently. And then they expanded it further to have a 25-year quit smoking history. And as you can see, across just these three different criteria, there's still more patients that could be enrolled if there was an expanded criteria that was there. And then furthermore, you can kind of see the different colored graph and the different racial groups that they represent. Despite expanding these criteria, there's still quite a significant racial disparity that exists, telling us that even with the expanded criteria, we may not be capturing all of the patients that we could be. And then lastly, if you kind of evaluate male versus female, you can see that overall females, even again, despite the expanded criteria, seem to have a lower eligibility to incidence ratio. So even though we've made significant changes in our criteria, there's still that racial disparity that exists when we look at lung cancer screening rates. This graph was published in 2018, and it looked at patients that were eligible for lung cancer screening in specifically, states with higher smoking rates. So you can see kind of in this Midwest South belt, up to 13% of those states' populations would be eligible for lung cancer screening. Now, if we look at this graph that follows, even though there's a significantly higher percentage of patient populations that exist, the US average for patients that are eligible but are being screened is only about 5%. And then for my state specifically, here in Georgia, we're at about 6%. So a little bit better than the national average, but still nothing that we should be proud of, because that's only 6% of the eligible population that's actually being screened with these lung cancer screening exams. And then the last thing that I mentioned was the adherence to screening. So in this study, they looked at quite a few studies and pulled together the adherence rate for these patients to keep coming back for their follow-up scans. And the adherence rate was anywhere from 12% to 91%. And on average, it was about 55%. So about half of the patients that get their first initial scan will come back to follow up and have their scans after a year, after 6-month follow-up, whatever the guidelines dictate. As you can imagine, there are certain characteristics that are associated with higher adherence rates. So certainly patients that are former smokers are more likely to come back for their adherence exams. White patients are more likely to come back for follow-up exams compared to other ethnicities. Age seems to play a role, where patients between the ages of 65 to 73 years of age will come back for their screening exams. And then education level. So patients that have had a college degree or more than 4 years of college education are more likely to come back for their adherence exams. This was another study that, again, looked at adherence and non-adherence for patients when it comes to lung cancer screening. It was a pool study, and as you can see, anywhere from 14% to 63% non-adherence rate, with an overall rate of about 28% non-adherent patient populations. One thing that's also been looked at when it comes to adherence for patients to keep coming back is whether the screening programs that they were enrolled in were centralized programs or decentralized programs. And so lung cancer screening programs really come in these two flavors. A centralized program is something that will be organized out of, one single office or one single group, whether it's the radiology group, the pulmonary group, thoracic surgery, but they have one kind of team that works together to work through the joint decision making. They work together to coordinate follow-up exams, CT exams. They work together to coordinate procedures if the patients need it. Versus a decentralized program is patients that are being independently followed by physicians. So whether it's a primary care physician that's ordering the annual CT exams, or it's a pulmonologist that's kind of managing their own patients. Patients that are in a decentralized program, of course, will go back to that single provider who's following them. And then they'll refer that patient out to further subspecialties as they feel fit. So in this study in 2021, they actually looked to see kind of the impact of centralized versus decentralized program when it came to patient adherence. And they noticed that in centralized program, about 46% adherence rate versus a decentralized program, where it was about a 35% adherence rate. And then last but not least, kind of looking at future of lung cancer screening. So there's a lot of new technologies that are coming into market, specifically when it comes to AI. There are a lot of nodule detection algorithms, deep learning, that's kind of working and trying to determine how lung cancer screening exams can be evaluated by AI models. There's been studies that have looked at how efficient AI models are when it comes to detecting lung cancer, malignancy with lung cancer. There's also talk about using AI to reduce potential errors that may exist with variability when it comes to radiologists reading the scans. I think this is all still kind of in the working stages. I don't think there's been one particular model that has been looked at that has been identified as kind of the gold standard. I think there's a lot of biases and kind of fairness and accountability questions that come into mind when we look at AI models. As you saw, there's still kind of racial disparities that exist within the lung cancer screening population, and a lot of the AI models are learning their algorithm based on patients that are currently enrolled in a screening program. And so one of the concerns is, are we perpetuating those disparities further if the AI model is being tested and reproduced in a certain population? So I think there's more to come in the world of AI, but certainly something to keep on our radar as lung cancer screening continues to evolve. And then one interesting study that I found, this was a study that was conducted at Stanford University. It was specifically in women that were between the ages of 55 to 74 years of age, who had actually undergone breast cancer screening. And what they noticed was that out of 874 women that were enrolled in the study who had underwent breast cancer screening, about 99 were eligible for lung cancer screening. And of those 99 that were eligible for lung cancer screening, only 35 of them, so about 35% of them, actually got screened. So that clearly tells you that, you know, although there are certain cancer screenings that were good at coordinating and ordering, lung cancer screening, one, doesn't seem to come to our forefront. And two, there's been talks about, you know, is there beneficial to combine multiple screening programs into one where, you know, if patients are coming in for a breast cancer screening exam, do they also kind of get a combined lung cancer screening exam? And so this is something that could make an argument for, okay, if we're doing a great job with breast cancer screening, then combining these two items into one program could potentially lead to more patients that are being screened. So something interesting to think about when it comes to the future of lung cancer screening. And really that was kind of it as far as the didactic portion of this goes. I hope I was able to kind of convince you that lung cancer is the leading cause of cancer-related mortality. Lung cancer screening is important when it comes to decreasing mortality. And then certainly the new 2021 recommendations that, you know, you should always have in the back of your mind, whether you're seeing patients in primary care clinic or pulmonary clinic or even in the hospital, for something for them to do in the outpatient setting. And with that, Dr. Icard, I wondered if you could share a little, I guess let me ask if there's any questions first. I don't see the chat box.
Yeah, I don't see anything in the chat box, but nice to meet everybody. I'm Bradley Icard. I'm a pulmonologist in Greensboro, North Carolina. You know, something else that I would just like to, you know, thank Dr. Gupta for sharing some of the background details and facts and all of that we know as to why lung cancer screening is important. But, you know, one of the things that I want to think about too, when you think about the future of lung cancer and lung cancer screening, you know, we've got to take into account the category of the 1 in 5 patients that get lung cancer who are non-smokers. And so, we can't forget that radon is the second leading cause of lung cancer in the United States. So there's campaigns with various groups to help, check radon in homes where people live, but secondhand smoke exposure, all the way things from smog to lung transplant. And, one of the things I was recently introduced to was the data in behind the cities like Taiwan. In the 1990s, they had very low levels of lung cancer in association, but as the city has grown and gotten bigger and there's higher smog rates, it has increased the number of adenocarcinoma diagnoses in places like that. So these are all things that we've got to think about. Actually, the Chinese Ministry of Health this past year updated their screening guidelines to include family history, secondhand smoke exposure, and then certain areas within the country that patients live that have a higher incidence. So I think that, as our guidelines grow and change, it's going to take some time before we get there. But as a collective and as a group of clinicians and advocates for lung cancer screening, we got to think about that moving forward, those different areas. The FANS study data was released this past year at the World Congress in 2023 of lung cancer, and the prelim data was looking at 1,000 Asian females that had EGFR positive, a total of 1,000 Asian females, but 1.5% of that population had a diagnosis of cancer. So there's obviously some genetic predisposition to that for sure. To tell you a little bit about our program, we've started just like many when I guess it was probably, 2013 or so, when they first started to receive coverage with insurance companies for LDCT. And it's just organically grown over the years. We have a wonderful team of coordinators that help manage that now, with nurses and a very dedicated APP, Sarah. She's awesome. She's been really doing great work with keeping up on top of scans and recruiting patients into the program. In 2018 or so, 2019, we were screening about 1,800 system-wide, and now over the past 5 years, we've grown the program to just under 7,000, so probably about 6,500 or so patients a year within the health system. So these are all wonderful, wonderful things for sure. Let's see here. But I don't know, Dr. Gupta, you want to tell us a little bit about your program?
Yeah, absolutely. So our program here at WellStar first started in 2008. So it's been in place for a little bit of time. But as you can imagine, early on, we were struggling to have these scans be covered. Of course, once guidelines came into place, a lot more people were being scanned. Currently, right now, we have a total of about 16,000 patients that are enrolled in our program since 2008 to now. And monthly, we're getting about 230 patients that are coming in every month that are new. And for us, our program, we have nurse navigators, and we have kind of our coordinators that call patients. We'll follow up with them, try to get their appointment scheduled. And the patient referrals come from all over, whether it's primary care providers, whether it's pulmonologists, thoracic surgery, any place that the patient exists, we will find them and get them enrolled in the program.
That's awesome. Well, I think it's a good segue into some polling questions. And so what I thought for our section, my portion of the talk, would help kind of facilitate some of you guys that want to, we're going to start by answering some of the poll questions, and then that'll hopefully stimulate some discussion. And if you would like to come off mute to ask us questions or have a discussion, just raise your hand in the webinar, and then Emily will do such. So Emily, if you want to throw up our first of 5 questions, go ahead and put your first question up. If you guys will click your screen and vote. Do you have a centralized or decentralized lung cancer screening program for your health system? And when I say centralized, that means like, is it within its own housed program, or is this something that's done kind of widespread amongst, you know, everybody and the kind of doing their own thing? Emily, I can't see if everybody has.
Yep, I see some people still voting here, so I'm going to give it a few more seconds and I will close this poll out so you can review.
Okay, great.
I think majority voted, so I'll close this one now.
Perfect. There we go. So majority of folks in the program have a centralized system. We do as well. Any comments, questions back and forth on the pros and cons of centralized, decentralized? I think one of the things that Dr. Gupta pointed out is there is a little bit of data that centralized work helps with adherence. And I think that we would probably all agree with that a little bit, is that having a centralized option does help when there's a team for adherence to the program. Any comments on how you guys run your centralized program, Dr. Gupta?
Yep, and so for our centralized program, it's based out of our surgery group, but of course with heavy involvement from the pulmonologist. And again, for me, I think it makes sense to have a centralized program, right? Because it's one team that's following this patient as an independent provider. Certainly as a pulmonologist who sees, you know, how many of our patients in clinic, it's nice to know that someone is taken care of, putting in that order that I don't have to remember 6 months from now for a patient who needed a 6-month scan. So I personally think that a centralized program is the way to go.
There's definitely some advantage to that, especially with the EMR, right? So the way the EMRs are designed to have something that is able to categorize and follow patients. We use Epic where we're at, and the Epic EMR to be able to build dashboards, excuse me, be able to build dashboards and other kind of things like that to help us keep up with patients, to prevent folks from falling through the crack. Do you want to throw up the next question, or the next poll? So who completes the majority of your shared decision-making visits? So is it registered nurses? Is it APPs, pulmonologists, primary care providers, or is it just kind of completely random? Everybody does a little bit of it across the board. And we'll let Emily close it out when most people have finished voting.
Up, it looks like we got another vote in. Okay, I'll close this poll out now.
Perfect. Yeah, looky there. We're kind of split across the board. It's interesting that 0% of people said registered nurses. So it's something else that I think is important to this process, is that everybody kind of practicing at their highest level. And you know, the shared decision-making visit per CMS is a G code that is billed out to patients, and registered nurses and care coordinators are able to see patients with shared decision-making visits and able to bill those out. So we actually have nurses in our group that do the shared decision-making visits, and we have some, predominantly it's advanced practice providers. We're kind of in this hybrid zone right now where we're working to try to transition some of that work to RNs to be able to help facilitate the need, honestly. Pulmonologist, I fall in that category. If I see a patient in clinic that needs a shared decision-making visit, by all means, I try to go ahead and do it, and then send the referral over to our coordinators to pick up and make sure that the scan falls into one of their work queues. And then primary care providers, of course. One of the things that we have done is worked with our EMR to develop a best practice advisory that occurs when the patients are being seen for their annual physicals. And if they qualify for lung cancer screening, then it can help auto-populate into that. So we got a question that came up here. I want to make sure I don't miss them. It says, question 1, who performs the screenings? Well, for like I said, for us, have a small portion that, so to do the screenings, that would go through the radiology department, right? And so we have a couple of different outpatient CT scanners that we have held CT slots on that our patients get scanned on for sure. And then the people that do the shared decision-making visits, we just kind of talked about. And then the last questions here, it says, any surprises or learnings you've faced when switching from centralized to decentralized to centralized? Oh man, that's a heavy hitting question. I'll let Dr. Gupta start first to see if she wants to answer, and then I'll layer on.
So I have to say that I've been blessed to be in a place where I started my position when there was already a centralized program in place. However, hearing stories from providers that have been here before me and were in the program before I started, I think one of the biggest challenges that they faced was just getting the word out about what a centralized program is. I think there was, when the program was initially set up as being centralized, there was a lot of apprehension from the pulmonologists, from the primary care providers, that we were taking away their business. And so it was hard to kind of explain like that this is actually an extra measure of support, if you will, to where you can focus your 15-minute clinic slot on other things and let us worry about this lung cancer screening. I think and this probably we address in our question later on. I think there was also a financial kind of aspect to this to think about, where the centralized program, of course, requires more resources, and that will come from some place or another. And lung cancer screening itself, unfortunately, does not generate any revenue for the hospital systems. But of course, there's downstream revenue that comes out of this. So I think kind of putting that into perspective for our C-suites when it comes from going from a decentralized to a centralized program, I think those probably are two of the biggest things that I've heard mentioned when I hear people talk about the shift of that program.
Yeah, I think it's an alignment thing, right? What you want to do is offer support to, especially from a primary care standpoint. One of the things and one of the barriers that I helped overcome was that I met with all of the primary care divisions at their meeting, like their lunchtime huddles or meetings and stuff like that. Kind of let them know what the team looked like, let them know what product we were going to deliver, and then tried to hold true to that product, meaning that, hey, we're going to contact your patients, we're going to let them know when they need to be scanned, and then we're going to get the result back to you so that you're aware of it. And so trying to make sure that we deliver on those things. And then one of the things is, as part of that, we make sure that we tell them if there are patients that are found that have, lung rads 4 concerns, that we're going to make sure that they have timely access and follow up to where they need to go into nodule clinic, et cetera. And when it's packaged that way, it's less of like, hey, I'm taking something from you to do. And actually, it was really kind of roles reversed a little bit. They were super glad to like have something to take off of their plate, right? Because they're busy managing everything else under the sun. And then to help, as they got comfortable with the centralized process, we then kind of leverage data again. I like using data to help make decisions, and we leverage data amongst the practices on who was using that new BPA that I talked about within the EMR. And physicians are competitive, providers are competitive. So you show them a chart of all of the 30 separate primary care practices and show them who's in the lead and who's lagging behind on referrals for lung cancer screening, and month to month they continue to climb. And so that's how we've been able to nearly quadruple our screening volume in 5 years. And it really is for the betterment of the patient. At this point, we're doing about 320 or so on average annuals a month. And I, encourage the lung cancer screening team to make sure to put another tally down, because we've saved one more life when you look at the data. So it's one life a month is pretty awesome. All right, Emily, you want to go to the next polling question? All right, how many lung cancer screening CTs are performed yearly at your health system? Just kind of give us a little smattering of, are we in the greater than 10,000 range, which it's, you know, WellStar has had a long-standing history of lung cancer screening, so they're in that 10,000 mark. We haven't quite got there yet.
Dr. Icard, while
Yeah.
folks are responding to this question, maybe you could comment on a little about how you went about kind of balancing your clinical time with going out and doing almost like these road shows with primary care providers, because I think that's one thing that as clinicians we struggle with, is not having any inbuilt time to take away from clinic or get away from clinical duties to go kind of create awareness about this.
Yeah, absolutely. I am fortunate to have two very active nonprofit organizations in the state regarding lung cancer, and that's the Live Lung Foundation and the Lung Cancer Initiative based out of Raleigh. So I love to leverage their support when it goes to community awareness. And then for internally with the health system, excuse me, if there was one good thing that came out of COVID, that was virtual meetings. So I tried to jump on the calendar of all the virtual meetings that I could, and then just say, hey, I want 5 minutes at the top of the meeting. And so then I would just kind of jump in, give 5 minutes, give them a blurb, show them some cool pictures from one of the robotic cases or something like that, to, you know, gather their attention, or if I had a specific story associated with that practice, I would take that patient's images and show them the patient that they care for out of their own practice. And so that really makes a huge benefit and connection when they get a chance to do that. All right, well, we got a couple here in the, well, we got a big group. It's either less than 1,000 or in that 5 to 10 range. So if you guys have questions, if you guys want to chime in or ask us or type them in the box, I'm interested in the folks that are, you know, able to maintain such high volumes. You know, we currently have 3, well, like 2.5 maybe FTE of nursing coordinators and 1 APP. Anybody willing to tell us kind of how many coordinators, or is it just kind of one person running the show? Anybody wants to share that? I'm always interested in how many like people and resources, because I'm always begging for resources, right?
Yep, those resources are hard to come by. So here at WellStar, we have a very large kind of geographic area that we can cover with all of our satellite locations. And so for us, we have about 4 or 5 nurse navigators that are somewhat assigned geographically to certain sites, but at the same time, they kind of cover all the patients that come through the lung cancer screening program. And so with those nurse navigators, you know, they're responsible, like I said, for reviewing the results, for placing those follow-up orders. If there's cases that they're concerned about, you know, lung RADS 4A or higher, they'll send it to a physician to review. And then we have kind of what we call a STAT clinic in place, kind of like a tumor board, but also like a multidisciplinary clinic with us as IP, thoracic surgery, radiation oncology, and med-onc that's there. And so we get patients scheduled into this clinic, and we're really able to kind of give them a comprehensive evaluation and say, okay, this is what we're seeing, this is your bronchoscopy procedure, or if the patient's had a path, then they come back to see the radiation oncologist along with the med-onc, you know, whatever they need. So it's a all-encompassing clinic from that standpoint.
Absolutely. And I think one of the things to remember is that, you know, when I'm describing programs or talking about programmatic development, I look at our surrounding colleagues, right? And I try not to reinvent the wheel. But, you know, critical AS patients, you know, the cardiology service lines have done a very good job at building business models and patient pathways for addressing folks with severe AS. Predominantly because that particular disease has a very clear defined endpoint. And that defined endpoint is either hospice care or they're TAVR candidates or open candidates for surgical valve repair by cardiothoracic surgery. And so it's a defined revenue stream and a defined endpoint. And one thing that's hard for incidental nodule management and lung cancer screening nodule management is there's not necessarily a defined endpoint. We may have nodule patients that end up at rheumatology because it's a necrobiotic nodule for rheumatoid arthritis. We may have nodule patients that may end up in infectious disease clinic because it's NTM, or back in pulmonary because it's sarcoidosis. Not every single thing that we find or handle or manage ends up in a operating room space for a lobectomy, which ultimately drives revenue for the health system. But our goal, if we do a better job with lung cancer screening, we have less lung cancer patients sitting in an infusion chair, which is a very hard concept when you think about business modeling, that we want to remove patients from receiving systemic chemo, because it is something that drives revenue. But we want to do that because that increases, the YPLs of a patient. It's one of my favorite acronyms, YPLs, years of productive life, right? So if we are able to catch patients early, then we can intervene and they can live longer. Emily, you want to do our next poll? All right, what is the greatest barrier you have encountered while expanding your lung cancer screening program? Shared decision-making visits, adherence to annual follow-ups, capacity, and financial investments for resources. I think we've talked about all of those this evening. So I'm interested to see what the audience thinks as their greatest barrier. You just get to pick one this way, force you to make a decision.
I think it would be hard for me to pick just one.
I know. I can, over the past 5 years, I could see a barrier at different time frames along the way for each of these. All right, drum roll. Let's see. Oh, look, everybody thought SDMVs were good. Adherence to annual follow-ups. Yes, I think that the 1 millionth screened clinical, or I guess it was like, I don't know if it's just like an update or some data look back this past year. They looked at the ACR data, registry data, and I think it was what, 22.5%. Don't quote me on that number, but it was pretty low for adherence of annual follow-ups. Capacity, I think that's, if I had to rank them, that's probably the lowest one for me. That was a problem for a while. And when I say capacity, there's really a capacity problem at two ends, right? It's capacity to get the shared decision-making visit done in a timely fashion, and then capacity of getting the CT scan completed, right? And some of the ways we help overcome that is to ensure that we leverage all of the capable people to do the shared decision-making visits, whether that's APPs or RNs, and then ensuring that we worked with our radiology colleagues to block different slots and times throughout the day to have our scheduler to be able to just kind of drop those patients on the schedule. So that's one good way to kind of help manage that. And we also realized there was patients that needed to get theirs done, but may work second or third shift, and like other things about timing throughout the day, or have difficulty with children, childcare, to be able to get it done. So they were fortunate to even open up some lung cancer screening slots on some of our community-based CT scanners at our med centers on the weekend. And so that's, just kind of think outside the box and talk to people. Financial investment, I think we kind of already touched on that a little bit. but that's always something. One of the ways to help when you're having these discussions is, I look at things that try to speak the language of the, I'm not an MBA or MHA, but when I think about programmatic development, you need to follow those patient paths, right? And I'm a very visual person, so I try to put those visual cues up when I'm having these discussions, but also looking at the contribution margin of those steps, right? So what does the contribution margin look like for a APP doing this discussion versus a registered nurse? Well, guess what? APP is doing it probably a negative contribution margin. They make a whole lot more money than registered nurses. And so when you start thinking about that, that's, how do we leverage to get the patient in more of a timely fashion? Who is it easier to recruit into doing that? And then thinking about the CT scans, right? How do you do those, and where's the most advantageous place to do them, right? Well, an ambulatory imaging center is the best from a reimbursement standpoint. So these are kind of things to help leverage as you make those financial plans to ensure that your plan lines up with the best patient care and the best option for the outcome for the health system. I know we're getting pretty close on time. I think we have one last poll just for fun. So who do you think should be the ultimate lung cancer awareness champion?
And Dr. Icard, while people are answering this question, you mentioned a couple of times loving data and kind of using your EMR to have some things set in place. I wonder if you could talk about if you're using any sort of software to track your lung cancer screening patients and their outcomes, or is it a dashboard that you have in Epic? How do you track patients?
Yeah, we work with our Epic build teams, and the Radiance team with Epic, they did a fabulous job to build a dashboard that helps just, for all intensive purposes, a fancy filtering system that ensures that we get those. Thanks for everybody jumping on the bandwagon for sure. But what's what we do? We use that dashboard to help that. We also have a natural language processing software that helps on the back end for incidental management to help drive those, but strictly for the lung nodule or lung cancer screening program, that all gets filtered through that dashboard, and that can be effectively searched and filtered by the ordering provider, because we still have patients that maybe the primary care does that annually with their physical. So we let them continue to do their own thing, right? And we offer them support if they need it. And what we've learned is that if we just continue to offer that support, eventually it's like, oh yeah, we've done it for 2 years. You take over year number 3 because I'm going to forget. And so it's slowly starting to change. And then we also tried to make it really easy by having a separate referral built into the EMR. So that way, all you got to do, you type in lung cancer screening, hit the button, and it's, without being cliche, the Staples easy button option, right? If you do that, folks, it makes it simpler long term. And we'll put a plug out. So if any of the folks here that are on tonight are not SAB members, there's a floating QR code that comes by. Feel free to join the group. We have I think an awesome group of people, like-minded, interested in helping patients across the country. And every time I do one of these or have an opportunity to meet friends and colleagues, I learn something new to take home to our program. But
this has been a great session. I've enjoyed hearing a different perspective on lung cancer screening, and especially kind of navigating through all of those challenges and how to leverage some of the things that we know to be true, but kind of translating it into the language of the C-suite and getting kind of stakeholder ownership from them.
Yeah, it's kind of about building those pillars of team members that are involved. And as as you do those things, make sure to share the stories, right? And so that's something that I encourage. I have a pretty significant anchored bias when it comes back. I always kind of pull it back to the patient. And so we've had the opportunity to do a couple of news stories with our local newspaper, a few stories on TV, and try to do some lung cancer awareness things on social media, and just bring those things out, because ultimately everybody feels good when they hear a story of a 57-year-old that has a new diagnosis of a stage 1 that gets resected, and now they're off to live their life cancer free. And more and more of those that we do. One of the things that we also do is make sure to track your data, right? Nobody, it's hard to share your story if you don't have the cred to back it up, right? Yeah. So in 2018, 2019, we started with about a 26% early stage lung cancer or stage 1 lung cancer diagnosis rate. And you look at the state and national average, it's about 25 to 26%. So for where we were right at national average. I'm proud to say that in the end of 2023, we're at 36% stage 1 lung cancer diagnosis rates. So we've had an internal stage shift of our cancer population by 10%. And then, when I think about ways to describe it, when I'm sharing the stories with administration or folks that help supply the resources we need, this past year, that means we saved 40, or about 50, I should say, 50 more people in the Greensboro triad from stage 1 lung cancer. Because if we diagnose, 500 plus a year, then that's another 50 patients that had stage 1 lung cancer. So pretty awesome when you kind of boil it down to actual day-to-day data points.
Yeah, absolutely. Well, thank you so much for joining me today. We definitely appreciated having you and learning insights from you. And thank you for our attendees for coming and spending the last hour listening to us talk about lung cancer screening. As Dr. Icard mentioned, please join SAB if you have not done so. We have monthly webinar sessions. We have one in December as well. And we hope to see you at our next webinar.
Yes, thank you both, Dr. Icard and Dr. Gupta. It was very informative, and we hope everyone enjoyed the interactive polls. We do have Dr. Gupta joining us again next month on December 10th. So if you want to join us for this AI talk, it should be good. We also have another webinar on the 12th of December. It's sponsored by Noah Medical, so it should also be a good webinar to attend. And once again, thank you all for joining, and I hope everyone has a wonderful evening.
Awesome.
Thank you. Bye.